Okay, everybody. Well, good morning, good afternoon, good evening, wherever you are joining us from today. Thank you and welcome. Firstly, I wanted just to apologise to our USA audience. We weren't aware over in Europe that there was a changing of times over the weekend. We're not due to go into summertime for another couple of weeks, so apologies for the last minute change, but. Thank you for hanging on and waiting for us. So, welcome to the first month of a series of talks and case discussions where various diplomat speakers within the Orthomed network will be describing a case or two that they've been presented with during their many years of orthopedics and neurology. The first subject, as you've seen today, is cranial cruciate ligament disease. Before we get going, I'd just like to make a couple of introductions. First of all, my name's Simon Porter. I'm the sales and marketing manager for Orthomed, based in the north of England. And we're also joined by Charles. Charles is the sales manager based in the USA. So thanks very much, Charles, for joining us as well, and no doubt we will be your contacts moving forward. Most importantly, today is the two speakers. Very briefly, Carl Kraus. Hi, Carl. Thank you for this. Carl is the Chief of Animal Surgery at Iowa State Hospital, and Bruce. Thank you, Bruce, who's the Clinical Director at a specialty referral hospital over in Maryland. No doubt throughout these presentations, there'll be a couple of questions. So feel free to use the chat board and I will be able to pick those up. And at the end of each case presentation, we'll have 5 minutes or so to throw some question and answers. If by any chance we don't manage to get through them all, we'll be following up with you afterwards and we'll be able to answer any questions you've got there individually. So thank you all very much again. I'm going to hand over to Carl. Just bear with us while we share our screens, and I will make Carl the host as he can begin his. Hopefully, Carl, you have that.
I think we're good to go.
Excellent.
So Simon, give me a thumbs up if everything's good.
We're all good. Wonderful.
Okay. Thank you, Simon and Charles and everyone with Orthomed. Sort of happy to be here and sort of excited. This could be a lot of fun because we can sort of interact in a more informal way and get just a lot of people involved and a lot of questions and everything. I was asked to talk about cruciate disease and I thought maybe I'd talk about something that had a little bit of controversy and a little bit of frustration. So that's why I chose considerations in giant breed dogs. So we'll talk about that, and we'll go through not just one case. I'm going to go through a whole bunch and just sort of like throw some concepts and concerns up to the group and see what other people's feelings are. This is a sort of uncommon, but happens frequently enough, just a big giant breed patient. This was a 6-year-old male, 3-month history of lameness, had cranial drawer, cranial tibial thrust, medial buttress. Pretty sure I could feel a meniscal tear, and it was just huge. This is 85 kilograms or 190 pounds. And so here were the pre-op images showing, not too much osteoarthritis, osteophytes, just a little bit off the distal patella, a little bit of effusion, but nothing too awful. Certainly he had cruciate disease. This left was most affected, but you could tell the right was going to happen pretty soon. This is what I did, and this is what I like to do. And I'll tell you reasons here in a little bit. But anyway, so I put a 8-hole TPLO plate and then slid a SOP just caudal to that. And the SOP, because of it's sort of narrow, just sort of sits right there in back of it. And so I sort of like that. And this is what it looked like at 12 weeks. And it's sort of interesting. You can see that he has some patellar tendonitis, a little bit of effusion. The knee otherwise looks really quiet. But this is a relatively long period of time. And if you look at this really closely, at this osteotomy, it tells you a lot. The reason it tells you a lot, if you look at this callus forming over here, and sort of, I think it looks like a parrot's beak, if you will. But what that says is that there is a relatively high amount of interfragmentary strain. Even with all of this implant, very robust, lots of screws, the implant's doing fine. The fibula is intact as well, and there's still a rather large amount of interfragmentary strain. It's healing fine. There isn't any problems, but there's still, some motion which is causing the stem cells in this area to follow more of a chondroblastic lineage. And then, of course, as is common with secondary bony union, which we're getting here, is that we get the callus and then finally bridge on the transcortex. So there's some considerations when we talk about giant breed dogs. I mean, which technique are you going to use? Where's your osteotomy going to be? Real specifically, yeah, we're going to make a general osteotomy, but where's it going to be? You better watch out for subclinical medial luxating patellas, but that's a whole nother topic of how to deal with MPLs. What implant we're going to use, and then the big thing is infection. We'll talk about that and what I do to deal with that, because in giant breed dogs, infection is probably one of the biggest problems that we have to deal with. Okay, which technique? Of course, you have a choice of more than one. I'm not even going to talk about a lateral suture technique because I wouldn't even consider it in any time whatsoever with these giant breeds. But if you're going to talk about the TPLO versus the TTA and MMP, and I'll group those two together just for simplicity. I know there's differences between those two in both theory and practice. But I will choose the TPLO. And the reason is that I have a little bit of trouble with the theoretic mechanisms of the TTA and MMP, in that if you have to change the angle of the tibia plateau and patellar ligament, anything over 27 degrees of a tibia plateau angle, you're talking about advancing that tibial tuberosity quite a bit in order to both theoretically and practically counter the tibial femoral shear and the tibial dynamic tibial translation. And so if I see a patient that, okay, I have to advance it too far, and I don't, I still postoperative see that tibial translation, I just don't feel good about that at all. And with the TPLO, you can rotate them, into the mid 30s down to about 5 or 6 in most situations, almost always situations. With the TTA and MMP, you have really large advancements in order for you to get that tibial patellar or the patellar ligament angle correct. And we're talking at least 15. And if you really look at some of these in giant breeds, you probably need to go more than 15 millimeters, which is just huge. That makes a large bony gap, and the osteon in a giant breed dog is the same size as in a small dog. And so the bony healing isn't like bigger osteons and bigger dogs. They're the same size. And so if you think about intramembranous, or even which we hope to get with those gaps with carriers or autogenous, grafts that we use, it's still a matter of diffusion. And so big dogs have a matter of diffusion of nutrients down to the cells, which is, the same as small dogs. And so the healing is going to be, sort of compromised, if you will. There are larger stresses on the implants. The stress on a tibia is not directly related to the weight. It is it is geometric, and so a smaller dog that weighs 5 kilograms. You usually multiply that times 4 as a general rule of the stress on the tibia, and you multiply a 100-kilogram dog by 4, and you're talking about huge forces. Huge forces. That would be 100 kilograms times 4. That's 400 kilograms. That is just huge forces on that. And so you have to really think about how you're going to do that. I don't know what the forces are on the tibial tuberosity, but I know they're big. And then the other thing is, for those of you that have had the joy and pleasure of removing either a cage or a wedge from a TTA or an MMP, boy, I would much rather remove a plate than try to dig one of those cages or wedges out, because those are, one is 20 minutes worth of unscrewing screws, and the other is just a nightmare. And yes, large breed dogs have higher infection rates. The other thing, another consideration is that when you are dealing with these giant breed dogs, that you need to turn your precision meter up to 10 or 11. You need to be far more precise, just because of the length of the lever arms that you have. If you're off by a couple degrees in a general 40-kilogram patient, your displacement at the distal tibia is not going to be that much. But you double that, and it is going to be that much. And once again, it's geometric. And so you need to really watch varus, valgus, and torsion really carefully. Like I said, your precision has to be up, and you better watch out for subclinical luxating patellas, because if you precipitate luxating patella after this, life gets complex really quick. For this reason, I will, and not a lot of people do this, and this is just me, but I will do a lateral arthrotomy for my TPLOs, just so I could see what's going on, of course, with the meniscus and the cruciate remnants, but also see what's going on with how the patella is tracking. If I need to really imbricate, then that's fine. If I need to do a trochleoplasty, which I do wedges, wedge recessions, I'll still do that. And you also need to think about maintaining that plateau bone stock, because as the bone gets wider, the cortices actually are relatively smaller. And that's because of area moment of inertia of the proximal tibia. If it gets big, it's stiff because of how wide it is, or how cranial caudal dimension it is. And so some of these really big dogs have surprisingly thin cortices. And so you have to watch out for that. So you need to maintain plenty of plateau bone stock. And whenever I can get, some locking screws in there so they don't shear out, they would have to slice through the bone, I'll do that. Once again, you have large lever arms, small area of tolerance. And one little, I call it a pro tip, if you will, when you're making the osteotomy, sight down the whole leg, meaning look down the entire limb. Put the stifle in 90 degrees, put the tarsus in 90 degrees, and make sure that saw is perpendicular, not just to the proximal tibia, because if you're myopic and you have a big buttress, or you have one of those slight curvature of the tibia, you might not think about the whole leg, and some of these legs are, it seems like a meter long. So be careful about the entire limb. And I'll put them in dorsal recumbency and make the osteotomy with the saw horizontal to the ground. So I'm looking at the whole leg up in the air and saw, like I said, horizontal, which not a lot of people do, but I think I can, like I said, sight down the whole leg. Because if you're not careful and you start to make that tibial tuberosity, you know, get either torsion of the distal limb or try to get that tuberosity inadvertently medial, then you might have some problems with the tracking of the patella. With these giant ones, I will add an SOP, whether I use an 8-hole locking or not. I will still add an SOP. And I understand that there's some controversy there because there's certainly a paper out of Dallas, and I know the people, of course, that published that said, well, you know, you're adding an SOP and significantly increases your infection rate. I don't see that in my practice, and I've looked for it. And I would much, much, much rather take a plate out than have a failure. Because taking a plate out is, you know, a half an hour's worth of work, and yeah, I'm sorry, and it costs a little bit more money, and you have to put them on antibiotics. But having a failure is losing a limb or euthanasia. So yeah, that's just how I feel. I will go to large degrees prophylactically prevent infection. And I'm going to go through all the different things that I do. So, well, here's just some example. This is another example of a giant brig dog. This one's 100 kilograms, huge. I want you to sort of look real carefully at the cortices. See, in the mid-diaphysis, you know, you have a pretty robust cortex. You get up into metaphysis, see how thin it is? And if you look at a normal-sized patient, the relative width of the cortex is not as great as it is in these great big huge patients when they have this big diameter. And like I said, it's a matter of area moment of inertia. Once you like the cylinder, it's to the width to the 4th power. So once you start getting really big width, then the stress on that outer cortex is less. And it's about the same because you have bending forces in the diaphysis, but in the metaphysis, you have to think about that a little bit. Here, you notice that we have a relatively high plateau angle. I would just estimate, I didn't remember the measurement, but I would say it's well over 30. And if you were to take this tibial tuberosity and try to neutralize, look at that. I know it's out of the screen, but if you were to try to move this so the straight patellar tendon is perpendicular to that, it would be in the next room. You just can't do it. So that's why I like to do it this way. So here we have used a 30 blade, which is probably a little bit too small for this size patient. You notice that his tibial tuberosity the osteotomy is starting to curve here, but we still have it perpendicular to the caudal cortex. So here we have a big 8-hole 3-5 with a 8-hole SOP slid next to it. Really easy to do, plenty of stock here. We have well more than a centimeter. I think this is like 15 millimeters of tibial tuberosity, so we don't have to worry about that. And still, even with all of that, you look and we still have that high interfragmentary strain. This is 12 weeks again. And you notice that he has that transcortical callus that forms, that little parrot's beak thing. And here in the caudal cortex, that osteotomy that was spot on starts to widen. That is high interfragmentary strain. He's going to heal. It's going to heal just fine. This patient, not a lot of patellar tendonitis, a little bit of effusion, but he was doing fine. But you know, sometimes when you look at that, you know that that there's just a lot of force on that osteotomy. Just looking at it a little bit more magnified, That is what we got going here. The bone is physically receding back in order to accommodate that amount of strain. The osteons will only tolerate up to about 10% strain. And when that happens, then the bone will start to recede until it gets to the point where that 10% strain is what the implants will allow. So anyway, let's talk a lot about infection because that is the biggest problem. There are higher rates in infection in patients, in larger patients, and some reports as high as 28%. Have a couple references there I'll be happy to give you, but there's plenty of references that document that in large and giant breed dogs, the infection rate is much, much higher. Our infection rate here for clinical faculty is somewhere about 4%. It's a little bit, it's about 50% again for residents. I'm going to get into that. But I don't see this infection rate. I just don't see it. And I did sort of an informal study in preparation for this talk. I looked to the last 4 years of implant removal, assuming that that would be my infection rate in large breed dogs. And we do about 250 TPLOs here. Surprisingly, it's not more than that, but in the last 4 years, I think we had 12 explants. And so, but we spend a lot of effort, time and effort in preventing infection by all different means. The clinical studies are out there. There's certainly a study, I think, out of Fitzpatrick's place, where he looked at locking plates versus non-locking plates and documented that locking plates have decreased infection rate. I don't see that here. Maybe if I look closer, I would. The addition of an SOP, there are studies that say that it increased infection rate, and another very, very good study, equally as good, that said it does not increase infection rates. And I could go on because it is a big problem. People have done many studies with adhesive drapes, antibiotic beads, even prophylactically, which I think is going a little bit overboard. Calcium sulfate beads, antibiotic impregnated, and everything about post-operative dressings. So there's a lot of subjective things. I'm going to go through some cases here that, like I said, that I pulled up in preparation for this study. These are all infected cases. So here is, and they aren't giant breeds. These are just every case that walked through the door and that in the last 3 years we've had to pull the plate out of. This is just a standard Slocum style TPLO plate, infected. Here is a Synthes locking plate, infected. This is post-op, of course, but it was infected. Here indeed is one with an SOP, a giant breed dog, which was infected. Here's another Synthes locking plate, infected. Here's another small 6-hole Synthes locking plate, infected. Here is a bilateral Synthes locking plates in a relatively large patient. Bilateral infections, so both of these plates had to come out. Here's another non-locking plate, but in a large breed dog, that plate had to come out. So here's another just standard TPLO plate that got infected. And so, you know, they don't just happen there was one case with the addition of an SOP and a giant breed dog that I had to pull the implants out in the last 3 years. And between you and me, I'm not going to complain about that too much. If you do, like so many of us, just do hundreds and hundreds of these, you're going to get infection. Out comes the plate. Not that big of a deal. We charge, you know, implant removal charge. Once the plate's out, the infection goes away. That's the biggest thing about trying to deal with infection. We'll put them on antibiotics based on culture and sensitivity until the bone's healed. Take it off, take another culture, another week or two of antibiotics, and I don't think I've ever seen a lingering osteomyelitis after the implant's removed. And of course, everybody knows you're not going to get rid of it if you keep the implant in, because of the biofilm that will form around the implant. So what do? I have zero tolerance for pyoderma. I mean, just a little bit, and I'll say, okay, we got it all clipped up, wash the whole patient, wash that up, home on antibiotics. Once the pyoderma's done, then we'll get you back in. And of course, not a lot of people like hearing that. And even though I look at the hair in the exam room and treat it there, sometimes it's not until they're anesthetized and clipped up that I'm able to really look at that skin. And that means they're anesthetized. I'm going to wake them up. That costs more money. And it's frustrating to everybody, but boy, it's not even close to frustrating as dealing with an infection. I use pre and 24 hours of post-op antibiotics. So we'll start with 22 milligrams per kilogram IV 30 minutes prior to the incision, every 90 minutes during surgery. Surgery usually takes about 90 minutes, even in the big ones. So that's about right. And then I will continue it for 24 hours and then stop. I don't send them home on antibiotics. This might be something that you'll disagree with. I do everything possible to reduce anesthesia and surgery time, but not by rushing, but by being efficient. So I tell anesthesia, guess what? I mean, we're gonna go through this. We're not gonna futz around on how to teach an epidural on this one, guys. We're gonna go in there and we're gonna do it. Do not use Nocita on these big ones, because it just looks too bad with after Nocita, and you're just using gargantuan volumes. So I'll deal with infection another way. Meticulous hemostasis, I just really ramp up the Halstead principles on everything I do. We'll go through liters of lavage before we start to close. So very careful about that. We'll be really fastidious about post-operative wound care. So they get a big bandage, and these bandages are big. I like big bandages, cannot lie. And so put bandages on there, make sure that they're covered, and make sure that they aren't, the soiling the bandage, and change it. And yeah, you're going through a lot of bandage material, but I'm going to change it to make sure if there is any oozing, that it's not going to sit right down on that incision. And I'll change it as often as needed, and I'll keep them in the hospital for 48 hours till everything's nice and quiet, then send them home. And we'll tell them over and over and over again, got to keep the e-collar on. They can't lick it. Don't treat this wound. If there's any problems whatsoever, come back in. I don't care if you're 2 hours away. That if there's any problems you have in trying to deal with this patient, I don't want that having urine on it, being licked, being moist, not being able to taken care of. If there's any problems, let us take care of it, rather than having you have to deal with it and allowing them to lick it and it gets infected. So every aspect of patient care just gets amplified for these, because I don't want to see infection. This was another 180-pound dog, which would be what, about 90 kilograms. This was a bilateral, so I did it staged. I won't do them both at the same time, because I've been doing these since 1997. And back then, when people started doing them bilateral, there was huge complications. Now these days we understand, you know, every once in a while I'll do a bilateral on a lighter patient, but not in these giant ones, because they have to protect it. So this one I did staged and had to postpone it for both surgeries due to pyoderma, but went ahead, healed fine. And the owner here was a guy named Gary Isles, who's from the UK, who happened to be my kid's football coach. That means soccer coach. And so he was not happy with me that we had to postpone it twice, but I'd much rather have that than have to deal with an infection. Here are some of the things that I don't do that might surprise you. I don't use adhesive drapes, even antibiotic impregnated adhesive drapes. I think with the World Health Organization surgical site infection document that was just updated within the last couple years, adhesive drapes do not decrease infection in these orthopedic conditions, and that's because during the surgery time, unless the adhesive is adhered down really, really, really well and doesn't flake up, if the bacteria are underneath that plastic, they will start to multiply. And then if during the surgery the adhesive starts to come up, it actually will increase your bacterial contamination of the wound rather than decrease. I do not continue antibiotics after 24 hours. There's no need for it. And that in addition to using multiple antibiotics. I will not polypharmacy antibiotics, good stewardship with antibiotics, because if it does get infected, if I put it on a fluoroquinolone and a beta-lactam at the same time, I can guarantee you if it gets infected that whatever bacteria it's going to be is going to be really hard to treat. So I just stick with straight cefazolin, straight beta-lactam antibiotic, and don't worry about that. Could care less about antibacterial suture. You know, you can use it or not. I think there's so many more factors involved with infection than the antibacterial suture that I don't think that it really matters that much. And yes, there are plenty of clinical studies that have not been able to see a difference between group. I will not allow an inexperienced surgeon to futz around on this for 2.5 hours. Says, guess what? Second, third year resident, we're doing this together. You're not going to do it by yourself, because their infection rate is not twice my infection rate, it's 3 times in these big size patients. And so we're going to do it together so that we're nice and efficient. Will not use Nocita. Like I said, it just looks too hot and nasty. And I will not discharge them early. I want to make sure that they get taken care of in my hospital under my control, so I can make sure everything's going well. Because trying to sling walk them around when they weigh more than the owner is a little bit much, and I can make sure I have my personnel doing it. They don't slip down, they stay nice and dry, they move them around in the cage so that they don't sit in a pile of urine because they're so large no one can move them, and so on and so forth. So anyway, that's what I have, and I'll open it up to discussion.
Thanks a lot, Carl. There's a few people joining us that only know you for the spine course, so they've been pretty interested to hear you talk about orthopedics. So thank you. There's actually no questions have come up, to be honest. Some people can be a little bit nervous about putting out questions in a public forum. So so if anyone's got any following on from this, then you know, feel free to get in touch. So no, that's great, Carl. Thank you ever so much. Oh, has there a question come on? Oh, just quite a lot of thank yous coming through. So Carl, thank you for that. Really, really good of you. Actually, one quick question. How do you diagnose infection?
Well, the WHO has a guidelines for determining infection. And of course, if I see a draining tract, there's serosanguinous draining tract, then I will just assume, with or without a positive culture, that it's infected. If I see that, and it usually happens, within the first, not 3 days, but usually 7 to 10 days, maybe 14 days after that. If there, of course, if it's swollen, if there is fluid underneath, that may or may not be infection. And so I will go ahead and do a deep aspirate. Do not drain the draining tract, because that's worthless. It won't get you where you need to go. You need to prep it and stick a needle down to where you see the infection. The problem comes when you have a little bit of joint effusion in the joint, because if you have an infection around the plate, no big deal. You have infection in the joint, that joint needs to be flushed. And so if I do see, if it's really painful, you have pitting edema in the distal limb, and there you usually always get pitting edema in the distal limb. But if you have all of those things put together, I'm going to assume infection. I will prep it. We'll get a deep aspirate from around the plate, send it for culture and cytology. And then if I think it's in the joint, and if it's in the joint, they'll stop using the leg. Even the big dog, it just hurts too much, they'll stop using the leg. And then you got a problem. And then you're talking about getting your arthroscope up and just flushing the bejeebers out of the joint and getting him on some aggressive antibiotic therapy. So anyway, bottom line is that all the classic signs of infection as defined by the World Health Organization, follow that up with culture.
Lovely, thanks, Carl. There's a few questions about MPL, but I think Bruce is going to address some of that in his presentation coming up. Just one last thing, and I think this probably applies mainly to the UK attendees, Carl. Nokita, can you explain a little bit more about what it is? We've not really heard of it.
Yeah, I don't want to get into Bruce's time here, but it is it's liposomal encapsulated bupivacaine. And so it's essentially long-lasting bupivacaine, lasts for 3 days. And so we really, really like that, because you don't have to give them narcotics. They essentially, their incision is anesthetized for 3 days. And so they're completely conscious. They're walking around. They just don't feel the incision. So it's long-acting, local.
Wonderful. Thank you, Carl. There's just to let everyone know that there's quite a few questions coming through, and don't want to eat into Bruce's time. So we'll make a note of all these questions that are coming through from everyone, and we'll put kind of like a nice Q&A together in the follow-up for everyone, if that's all right, Carl. We'll do it that way. Wonderful. All right, Bruce. Well, once again, thank you, Carl. I put a lot of time into that, so thank you. And I'll now hand you over to Bruce. Bruce, I'm going to make you the host. Hopefully you've got that through.
Yeah, so far so good. All right. Let's see. Here's this one.
Wonderful. Thank you.
Let me know when you can see my screen and everything looks good. Yeah. Is that all right?
Perfect. Thank you.
Perfect. All right. So I'll quickly go through these. I've got 2 cases highlighting 2 different conditions. There were some questions about MPL. So here's a patient, 2-year-old American Pit Bull, spayed female with a left hind lameness times 3 months, and diagnosed with a completely torn cruciate ligament, cranial cruciate ligament on the left, and concurrent grade 3 medial patelloluxation. And so this is something that, I don't know, I see fairly regularly in certain breeds. And it's always an issue. And just as Carl said, it takes some thinking about how you're going to approach the joint. And so one of the things that we look at very carefully on our preoperative radiographs and with the patient standing is, are there truly any femoral or proximal tibial angular deformities present? Because if they are, then that usually increases our worry about postoperative complications, and so and whether or not we need to include any additional surgical management schemes. So there was no suspicion of concurrent meniscal injury in this particular patient either. So preoperative imaging, standard orthogonal views. We do 90-degree flexion angles at the hock and stifle in order to plan our TPLOs as per the literature suggestions. But you can see here that the patient's patella is medially positioned. This isn't a perfectly straight film in this cranial, but you can see that the patella is there. One of the other things that we look at is the position of the patella. Is it riding sort of very, very high above the trochlear ridge? If it's sitting way at the top, we can do some measurements to determine if we have patella alta as well. And so some of the things that go into typical planning we'll do regularly. So here's preoperative planning using some templates, overlay templates on there to get appropriate measurements as to how we're going to put a specific implant on, whether it's the some different type of TPLO plate versus here we're also going to use the Orthomed ridge stop for this particular patient. I like using Orthomed's ridge stop. It's fairly non-invasive. It doesn't run the risk of accidentally dropping my wedge or my block, which I've done periodically and always get frustrated with that. So it's a nice way to do this. I almost always do a lateral arthrotomy for medial patella luxations now, especially in the bigger breeds with this. If they're really tiny, sometimes we'll do the medial approaches. And there is some issue with lifting the patella back over the implant, but we can talk about that as you go. So some difficulties, as I mentioned, for this particular patient. I don't know if you can see the actual measurements here. We using a 27mm blade to get 5 degrees post, we're looking at 12mm of rotation for a TPA of 30 degrees on this particular, 31 degrees on this particular patient. So for 12mm of caudal rotation, the actual plate location now becomes somewhat questionable and problematic, and that's why it's nice to use these plates that have this caudal angulation on there that helps you position the plate for a very caudally rotated if you have a big angle of rotation. And do we include a TTT, a tibial tuberosity transposition for these patients after you've built up their ridge? With the ridge stop, is there a need to sort of modify a TPLO to get proximal segment medialization that's been described in the literature? And then if you do not do a medialization and you do some sort of secondary osteotomy, how are we going to fix that tibial tuberosity? Whether or not we do a tibial tuberosity transposition and advancement, or an MMP tibial tuberosity advancement, as well as the transposition. All of these things are considerations, and I'll go through what some of these images look like. And then, as I said, I almost always do a lateral arthrotomy. I've had several failures. I'll say several. I've had 3 that I know of in the past year in 2020 that really plagued me. And I'll when I do the medial patella luxation specifically next month, I'm going to highlight one large breed case that I've been struggling with for a few surgeries, revising surgeries now. So I've found that if I do medial arthrotomies on some of these bigger patients, especially if they have concurrent cruciate tears, and I'm doing additional osteotomies distally on the tibia, that there's a bigger risk of lateral patella luxation postoperatively. So I've changed the Orthomed's recommendation a bit, and I'm doing lateral arthrotomies now. Just a specific thing for me. It may not be something that you might be encountering, but it's just something that I've encountered, and this seems to allow me to do a little bit tighter imbrication on the lateral aspect to prevent patellar luxation recurrence or lateral patellar luxation postoperatively. And as I mentioned, there's a little bit of increased work to lift that patella to reduce it over the top of the rib stop, but it can be done. You put them in very, very full extension and then gently lift that patella over the top rather than dragging it over and potentially damaging the implant. So here's what the modified TPLO with proximal segment medialization looks like. It was discussed in several papers. Fitzpatrick as well as Beal looked at that. Beal looked at it in really small dogs, and the technique does work to help medialize that segment and realign the quadriceps patella mechanism. His TPLO with the standard tibial tuberosity transposition, it does involve making an additional osteotomy on the tibial tuberosity, which adds significant risks for postoperative complications with more implants, of course, tension band and wire fixation, or K-wires, trying to sneak those around the screws of the TPLO plate can create some risks and potential misses and or iatrogenic trauma to the tibial tuberosity. And so it's very, very careful. It's not a technique that I prefer to use. I do prefer the medialization. I don't do standard TTAs, but I have done them. I won't say I don't do them. I have done them, but now I do the MMP almost routinely for tibial tuberosity advancement. And so this technique was also described as well, where you can do the advancement and medialize that tibial tuberosity. Lateralize the tibial tuberosity in order to realign the mechanism. And here's a case that I did fairly recently with a tibial tuberosity advancement and combined MMP and transposition in order to get the quadriceps better realigned. And so essentially you still do the same advancement, but you do have to pop an additional K-wire out through the lateral and proximal aspect in order to help stabilize that tibial tuberosity a bit more. And this technique seems to work pretty well. I haven't had any major issues with that. So in this particular dog, we did do a medial exploratory arthrotomy, and we did put the rib stop on. I'm sorry, that was a lateral exploratory arthrotomy. I apologize for that. And we put the rib stop on, and then did a shallow trochlear groove management with that. We saw that there was erosion of that medial ridge and no gross meniscal pathology. And she did have a 3 centimeter rib stop placed with no tibial tuberosity transposition. And I perform TPLOs now without a jig. I haven't used a jig for, I don't know, probably 10 years or something like that now, and quite happy with the results, and minimal dissection as well. And so she had, using the 24 millimeter TPLO saw blade, stepped down to the 24 rather than the 27 to avoid having to rotate as much. So did a 10.25 millimeter rotation, and then put the TPLO Liberty Lock plate on. And there was no modification of that proximal segment with no TTT. So pretty pleased with the postoperative outcome. And the only issue with this patient is that there was persistent lameness both at 3 weeks, 6 weeks, and 10 weeks post-op, with palpable effusion and crepitation in that stifling. These patients always have a full arthrotomy when they're done. But my partner, and looking at the meniscus, everything looked fine, but there was no improvement with this particular patient after analgesics or with physical rehab. So everything felt perfectly stable. Everything seemed appropriately aligned. The only consideration was that the postoperative radiographs at 8 weeks, you can see here, there's still effusion in the joint, at least effacement of that infrapatellar fat pad, and no significant progression of DJD, but static implants, as we can tell, no suspicion of infection based on what Carl was just suggesting. So an exploratory arthrotomy was performed at 16 weeks post-op, and a medial meniscal bucket handle tear was found, resulting in a subtotal meniscectomy. So when we see these latent meniscal injuries or post-liminary meniscal injuries, subsequent meniscal injuries, what is the actual cause? You know, sometimes it's because of meniscal pathology being overlooked at the time of surgery. Some patients have asymptomatic meniscal injuries, and what do you do with those? And then maybe we're underdiagnosing meniscal injury in some of these patients, even with severe probing, because it's difficult to actually see. I don't perform arthroscopy here. We have a needle arthroscope that we have used to sort of get a nice quick look in the joint sometimes when we're just not really suspicious, but we want to document that there's no meniscal pathology. And so I don't open every single joint myself, but as I said, my partner opens every single joint that he does TPLOs on. But is there a possibility that there was under rotation of the tibial plateau in this patient? You can see here post-operatively that this dog still had a TPA of 18 degrees after rotation, and that's what's stepping down to that 24 millimeter blade. So the dog started off at 31 and now still has 18. So I would suggest that this patient was slightly under rotated as a result, having some residual tibiofemoral shear that led to the meniscal pathology. I just listened to a podcast, not a podcast, a YouTube lecture by the guys at Kion, I'm sorry, and they were suggesting that the meniscus, Slobodan Tepic was suggesting that the meniscus is actually a good monitor for post-op tibiofemoral shear to suggest, have we done what we set out to do? And if the meniscus shows problems thereafter, that's a good suggestion that there's still residual tibiofemoral shear. The good news is that after that meniscectomy, the patient's lameness resolved, even though rehab was continued out through 20 weeks to try to make up for that loss of thigh muscle atrophy, and both client and dog satisfied. So we can do questions straight away if you'd like, or we can sort of wrap everything up at the end with questions on both.
We will just have one question come through, actually, Bruce, about how far can you lateralize the proximal fragment?
Yeah, the literature suggests all the way out to about 7+ millimeters. I haven't gone further than 7 myself, but you can do. Well, I'd be surprised if you have to do more than 7 millimeters. The reason being that if you have that much torsion or proximal internal tibial torsion, perhaps you need to do a corrective osteotomy rather than just lateralizing the tibial tuberosity. So I haven't gone further than that, but most of them come in around 4 to 5 millimeters or so. But it's case dependent, isn't it?
Great. No, thanks, Bruce. That was all for that one.
All right. Yeah. So the next case is Tucker, who's a golden retriever, 6-year-old Newton male. He had bilateral hindlimb lameness and localized to his stifles with cranial thrust bilaterally, more so on the left side. And so he was diagnosed as a bilateral cruciate tear with partial on the right and complete on the left. So preoperative measurements and planning for surgery, we see 31 degrees again with a 27 millimeter blade planned, coming around 12 millimeters of rotation. The other thing that I tend to look at on these that have significant buttresses, is there a lot of degenerative change on this medial side, which gives me a little bit suspicion that even if there is no palpable meniscal pathology, these cases have a higher incidence of meniscal pathology in my books, that if I see radiographic evidence of this and I palpate them, if there's significant crepitation palpated medially, especially during passive range of motion and internal and external rotation of the limb, of the joint, the so-called McMurray's testing, as they do in humans, I have a little bit more heightened suspicion. So these guys almost always will get an exploratory if I worry about that. So this particular dog had a medial approach, caudal medial mini arthrotomy, and a caudal medial hemimeniscectomy as well. I know it's controversial whether or not you remove half the meniscus, the only damaged bit, do a meniscal release. How much can you see from the caudal medial aspect? There's a host of things that can be discussed all in one go. However, that's what I did in this patient, and I almost say fairly routinely that's what I do for cruciate ligaments that I am managing with a TPLO. So put a standard, this is way back when I was still using the Curios TPLO Delta plates. So an older case back in 2017, I think. And post-operative TPLO TPA was down to 4.7 degrees, which is very, very good. The one thing that we did encounter was that significant medial buttress did make it challenging to localize our biradial saw positioning, and we ended up being slightly non-perpendicular with our osteotomy. You can see here, trying to get that perfectly perpendicular, we ended up a bit off, being pushed away by that medial buttress. And I think Carl's note of sighting down the limb with a horizontal sawing, I tend to do perpendicular sawing on the table rather than horizontal. But that's a neat consideration to try to sight down and make sure that you're getting true perpendicular cut. And then the other is off-center arc of rotation as well. You can see here that if that is the intercondylar eminences of that tibia, that's where we would like our center of the rotation to be versus where this particular patient's center of rotation ended up. So slightly off-center, and as a result, we changed the mechanics at the location of the articulation. And so you see TPLO central versus TPLO distal, and not only distal, but caudal to that medial collateral as well. And that's been looked at in several studies. Here's an ex vivo study by Cano and others back in VCOT that looked at the implications of what that patellar ligament moment arm does when you have a change in that positioning of a TPLO cut, very, very distal versus centered at the articulation of the joint. You change the length of the moment arm by shortening it, and you create much more work on that patella tendon. So 4 weeks post-op on this particular dog, the dog is extremely active, pulling on the lead according to the owner, feeling pretty good, had a nice, just less than 5 degrees of rotation. So a good stable knee that had no tibial thrust anymore clinically, but the patient was noted to have a bit of a hypermetric gait per our physiotherapist. They found that during the swing phase, there was a bit of circumduction on that left hind limb. And when they palpated the patella tendon, it was markedly thick. And more importantly, there was pain over that patella tendon. So you can see that markedly thickened area here compared to what he was immediately pre-op. So you could see notable thickening of that patella tendon just proximal to its insertion on the tibial tuberosity. And so physical rehab was initiated. They discontinued the underwater treadmill use, hydrotherapy, and then started with low-level laser initially. But 5 weeks post-op, there was still progressive thickening and edema in that patella tendon and in the soft tissues overlying the tendon as well. So they switched to phonophoresis instead. And phonophoresis is a technique that uses essentially ultrasound to drive an anti-inflammatory and/or analgesic gel deeper into the tissues. And you follow that up with cryotherapy after surgery. This was repeated in this particular patient out 7 weeks and 9 weeks. And the outcome showed that there was notably decreased patella tendon thickening, resolved edema, and the patient had to be maintained on gabapentin, carprofen, and a little bit of Dasquin as well. But clinically markedly improved, and the owner's quite pleased with the outcome. So with that, I will pop off. Let's see, right at 10 o'clock, made up some time. And sorry if I raced through there, but any questions at all?
I don't think there's anything come through, Bruce. So thank you ever so much for that. Like I said, we'll be following up with everybody. I know the passion that you and Carl have for passing on your experiences and your teaching. So thank you so much. Thank you everybody as well for attending.